with problems first and then over diabetes. Okay. This is a 13-year-old boy who's just been diagnosed with diabetes. He enjoys playing sports, and he recently has not been feeling well. His parents have noted that he is constantly thirsty. Is that a symptom of diabetes? And hungry, another symptom, even though he has lost some weight recently. And with type 1 diabetes, many times they do lose weight. With type 2, usually they are overweight, but sometimes you do see in type 2 that they do lose weight, but not as much as in type 1. He also complains of being tired. Fatigue, tiredness is another symptom. He did have what the parents described as flu some weeks ago. Remember we talked about type 1 as it's the result of an autoimmune response. And when you look back into their history, many times they've had the flu. They've had some type of viral infection. He is seen by his physician. His hemoglobin A1C is 8. What is that? Way high. A random blood glucose is what? 300? High. What should a random glucose be?
Under 126.
A random one should be less than 200. And in the hospital, we call them 2-hour PC, sometimes 3-hour PC, or you can just do it really randomly anytime that the doctor orders it. It's not fasting. He's hospitalized to bring his blood glucose level under control, and intense diabetic education. After intense diabetic education, he's discharged on basal bolus therapy. So what's the pathophysiology of type 1? We talked about it a little bit. I'm sorry? Yeah, they are insulin dependent.
Their pancreas no longer produces insulin.
That's right. The pancreas, actually, what happens when they have that autoimmune response is that the body sees the pancreas as foreign and tries to attack it, and so antibodies are produced. And so over time, the pancreas, those beta cells in the pancreas are destroyed. And so they no longer produce insulin. And so they have to have lifelong insulin therapy. You can't do anything else to treat them. I mean, there's no other medication to treat them, but they have to have a lifelong insulin therapy. We talked when we talked about type 1 that there is a familial tendency towards it. You see it in families that are predisposed to develop type 1 diabetes. If something in the environment, some toxin, a virus, or whatever, if this person is predisposed, they're more than likely going to develop type 1 diabetes. There's also a genetic component. And so the end result is that the beta cells of the aisles of Langerhans are destroyed and the pancreas no longer will produce insulin. So what are the signs of type 1 diabetes? We mentioned 2 of them in his overview.
Polyuria, polydipsia.
Polyuria, polydipsia, and polyphagia, and also it talked about he was tired. Fatigueness is one of them. Weight loss. That was one of his symptoms. His blood glucose level was high when he came in. Many times in children they'll have enuresis. They'll wet the bed at night. And you'll see the candida, the vaginal infection in girls. And also, a lot of times with children, and also sometimes with adults, when they're diagnosed, they are already in ketoacidosis. How's it diagnosed? How is type 1 diabetes diagnosed? And y'all need to know these ranges for the test.
Oral glucose tolerance test.
An oral glucose tolerance test, and what's the range for that one? Yes, if it's greater than 200, so less than 200 would be within normal range. If it's greater than 200, that's considered diagnostic of diabetes. What about the fasting blood sugar? Yes, greater than 126 on 2 occasions. Because, you can have an elevated glucose because of something you've eaten, and you might not necessarily be diabetic. You may have eaten a bunch of candy bars, and then you go to the doctor and they check your blood glucose level and it's elevated. That doesn't mean you're diabetic, but if on 2 different occasions, if your blood glucose level is greater than 126, then that's diagnostic of diabetes. And what about glycosylated hemoglobin? What's normal for that?
4 to 6%.
4 to 6. 4 to 6%. But I told you the other day that most of your doctors will not medicate patients, and this is type 2, because your type 1s have to be medicated with insulin. But with your type 2 diabetics, most of your doctors will not medicate unless the hemoglobin A1C is greater than 7. That's the normal A1C. That's the normal A1C. Okay, is this child at risk for long-term complications?
Yes.
Yes, and especially since he's diagnosed as a child, he's going to have diabetes for the rest of his life, isn't he? So what does he need to do to prevent those long-term complications?
Exercise, consistent control.
Yes. Keep that blood glucose level under control. Keep that hyperglycemia under control. He's at risk for kidney problems, the nephropathy, the neuropathy, which would be the legs, the retinopathy, which would be the eyes, amputations, atherosclerosis, peripheral vascular disease, all of those things. Because remember I told you that your diabetic builds up plaque in their vessels faster than someone who is not diabetic. So building up that plaque is going to impact perfusion to the tissue level. Perfusion of rich oxygenated blood to the tissue level. Okay, so he's at risk for all of those. Coronary artery disease. Okay, what's the treatment for your type 1 diabetic? The treatment...
Exogenous insulin.
What'd you say? Insulin. We're going to give him insulin lifelong. Now, because he's a child and he's growing, his insulin dosages are going to have to be adjusted as he grows. And as he grows, his insulin needs are probably going to increase. He needs to be under the care of a pediatric endocrinologist. If I had a child who was diabetic, I would want that child under the care of a pediatric endocrinologist. If he plays sports, if he exercises hard, then all those things need to be taken into consideration. So what the doctor will do is look at his activity level, look at where he is as far as growing, and look at his diet and all those things, take all those things into consideration as they plan his insulin therapy. He would be a good candidate for an insulin pump because you can put you do put rapid acting insulin in an insulin pump. And he's 13 years old. He could be taught to manage that. And then he could have that continuous amount of insulin infusing all day long, and then before meals and snacks and at bedtime, when he has a snack, he could give himself a bolus of insulin to cover his carbs. And remember we talked about the other day, 1 unit of insulin for every 15 grams of carbs? Okay, 15 grams of carbs equals 1 carb exchange. When I was telling you guys that when I was diagnosed, I went to the nutritionist and she planned out my diet and told me how many carbs I could have for each meal and for snacks. And so when I look at a carb, 1 carb equals 15 grams of carbohydrates. So if I look at a carb and it has like more than 15, then I may count it as 1.5, or if it's close to 30, I may count it as 2. But they really need to learn how to read labels. And so that's one of the things we need to teach him and his family is to read labels. And he needs to be evaluated every 3 months because he's growing, because he's a child, and because he's a new type 1 diabetic. What is basal bolus therapy?
Mimics your normal rate, or it should be.
Yeah. The doctor's trying to plan out his insulin therapy that's going to as closely match the insulin that's produced by his body. And that's why a pump would be so good for him. A pump would be so good for him because a small amount of insulin can be infusing into his bloodstream every minute. And that way it would closely mimic the way that his pancreas works. And then, remember we talked about the other day that when you eat, if you have a normal pancreas, it produces more insulin to take care of the food that you've eaten, take care of the carbs that you've eaten. He gives himself a bolus of insulin every time he eats, or every time he has a snack. And so that more closely mimics the pancreas. So that's what we're talking about. Now, some folks may have a morning and an evening dose of NPH. That may be their basal bolus therapy. It just depends on how they work out that it works best for this child. But I think an insulin pump would work very well for him because it allows a lot of flexibility for him. And it more closely matches the body, the normal body process that occurs. Okay, the next question is, let's talk about the differences between type 1 and type 2 diabetes. Let's talk about type 1 first. What kind of onset do we have with type 1?
Rapid.
Yes, it's rapid or sudden onset. A rapid onset. And what's the cause? Or what happens in the body? The pancreas is no longer secreting insulin because of that immune response that we talked about, right? What are the symptoms?
Hunger, thirst.
Yes, the 3 polys, the 3 sisters. Those are the biggie. Those are the characteristic classic symptoms of type 1 diabetes, although there's other things like we talked about them, fatigue, weight loss. We didn't mention blurred vision. Blurred vision is one too. Lethargy, tiredness.
Diaphoresis.
And many times when they present, they already have ketoacidosis. And they're going to need lifelong insulin therapy, correct? Okay, what about type 2? What's the differences?
Slower onset.
It's a slower onset. Many times, type 2 diabetes is not picked up until a patient goes to the doctor for some reason. In other words, most of the time, the symptoms of type 2 diabetes do not take a patient to the doctor. It's because the patient's gone to the doctor for some other reason, and with a workup, they figure out that the patient has type 2 diabetes. What's going on in the body? Are they making any insulin?
Yes.
Yes, they may be making insulin, but it's a decreased amount of insulin. What else is going on?
Or they're insulin resistant.
Think about those. Yes, the insulin resistant. Think about those cells. The cells
They're not able
have little receptor sites on them, and they're not sensitive to the insulin. So you have insulin resistance. And so a lot of your medications will counteract that insulin resistance and help the insulin carry the glucose into the cells, because that's what insulin does. It carries the glucose into the cells to be metabolized as energy. Okay? What kind of symptoms do we see? But not as profound as you do in type 1. You still can see them, but not as profound as in type 1. Do they lose weight?
They gain weight.
Yeah, most of the time they don't lose weight. Most of the time they're overweight. Some other things, just let me throw out some other things. Sometimes when they look at their blood work, their lipid levels are high. Many times they have hypertension. They also are fatigued. I think of the lady sitting in the chair, the fat lady sitting in the chair eating her bonbons. Yeah. Sometimes they, a lot of times they'll have sugar in their urine, and their symptoms have been present over a long duration, but they haven't probably really noticed them very much. Okay, the doctor has put this child on sliding scale insulin. What does that mean? Have any of you given sliding scale in the clinical area? What does that mean? What are we doing with sliding scale insulin?
Comparing it to their blood sugar.
Yeah.
AC and HS.
AC and HS. Does everybody know that AC means before a meal? And HS means, of course, at bedtime. The doctor will set up an order that says, give sliding scale insulin, and then he'll give us the ranges. And then he'll say AC and HS. Well, it goes with that order that we're going to check the blood glucose level, AC and HS, and then we're going to give a rapid-acting or a short-acting insulin, whatever the doctor orders, based on what the blood glucose level is. So the amount of insulin we give is based on a predetermined order that the doctor has written telling us how much to give. Many of these patients that are on sliding scale insulin also receive either an intermediate acting insulin like NPH. And the reason I keep talking about NPH is because NPH is the one that we give most in the clinical area. Lente is also an intermediate acting insulin, but I just don't see that given that much. So that's why I talk about NPH. They either receive an intermediate acting insulin or one of your longer acting insulins like Lantus or Levemir.
And that's like on a regular basis they would receive those?
Yes, along with the sliding scale. And remember when we talked about mixing insulins? You can mix Novolog and Humalog with NPH, but you cannot mix anything with Levemir or Lantus. Okay. The next question is discuss the different types of insulin. And so you have your rapid-acting insulins and your short-acting insulin and your intermediate-acting insulins and your long-acting insulins. When I think of the rapid-acting insulins, I think of them as by 15 minutes, you better have fed them. 5 to 15 minutes, you better have fed them. And for the most part, they last over about 3 to 5 hours. Now, your book's going to say a little bit differently based on which exactly one it is, but, you just kind of have to get it in your mind that, the onset's really rapid. And by 15 minutes, the onset's there, and it peaks in a couple of hours, and the duration's about 3 to 5 hours. Your intermediate acting insulins, NPH is the one that we talk about. The onset is 1 to 3 hours, but the duration, the peak, I think your book says 4 to 12 hours. Isn't that right? Doesn't it say 4 to 12 hours? Your book? I believe it does.
It says 4 to 14.
4 to 14? I thought it was 4 to 12. I think it's 4 to 12. But what I want to point out to you guys is that when you give these insulins, as a nurse, you have to think about when these insulins are going to peak. Because when they peak, that's when their blood sugar is going to be at the lowest. And that's when they're going to start having symptoms of hypoglycemia, especially if they haven't eaten. So you need to think about when they're going to peak. Because then if they start having symptoms of hypoglycemia, which are the nervousness, the sweating, the irritability, mental confusion, tremors, shakiness, those kinds of things, then that sounds like a hypoglycemic reaction, or insulin shock is another term for it. How are we going to treat that? I don't know if that's on here, but let's talk about how we're going to treat that.
Glucagon.
Well, glucagon, don't go there. This is an alert and oriented patient, but he's having symptoms of hypoglycemia. What's the simple thing we can
Like
Candy.
juice.
We can give them
Simple
orange
sugar.
juice, hard candy. Yes. Well, milk has protein in it, so we're going to give that to them over the long haul. We need to give a simple sugar real quickly, so his blood will take it up. Marshmallows. Hard candy, marshmallows. Lifesavers is an example of hard candy, and I think your book said 5. A half a cup of orange juice, which is 4 ounces. No, don't put any sugar in it. And then we're going to check his, and then 15 minutes later, if he still has symptoms, we're going to check his blood glucose level, and we're going to give him, if his blood glucose level is less than 70, or if he's having symptoms, we're going to treat him again with orange juice or Lifesavers or whatever we have on hand that's a simple sugar.
150 is when you do the glucose.
Well, we start talking about that when they can't swallow. And yeah, less than 50 because that's getting close to being too low. And remember, the brain needs glucose. And so that's where the mental confusion comes in. And then your long-acting insulins, they last up to 24 hours.
And they don't have a peak, right?
Well, one of them does. Now, when they first came out, and I can't remember off the top of my head which one doesn't have the peak. But when they first came out, they said that both of them didn't have a peak. But now they're saying that one of them does peak.
Lantus doesn't have a peak.
Okay, Lantus doesn't have a peak, and the other one peaks 6 to 8 hours. Okay. And let me say this to you again. When she's got that print off that I put on Blackboard, if you look at the times on that, they're going to be a little bit different from your book. Based on whatever resource you're looking at, sometimes the values of whatever you're looking at will be a little bit different, but they should be in the ballpark. So don't get caught up in that if the values are a little bit different.
But you won't ask us anything like
I'm saying to you, you need to know those things on the first page that I talked about, the values for the glycosylated hemoglobin, oral glucose tolerance, and the fasting blood glucose. You need to know that. And also, I told you in obesity, you need to know those ranges for BMI. Because there's some questions on the test that you have to know that to be able to answer the question. I don't ask you on a test what is the normal glycosylated hemoglobin because that's too easy. That's too easy. I give you a situation where you've got that information and then you have to decide what the answer is. That's application and that's nursing. That's application of nursing.
And there'll be like more than one value that we're looking at as a combination too. So that'll help.
Okay, where are we?
Number 10.
Okay, we talked. Yeah. Why does he have to check his blood glucose at least 3 times a day?
Stay stable.
Yes, he needs to stay on top of his blood glucose level for several reasons. He needs to prevent hyperglycemia so that he can keep those complications from happening, but also because he's a child and he's growing. And so he really needs to stay on top of his blood glucose level. And if they're constantly high, it's going to increase his risk of complications, long-term complications. We talked about the symptoms of signs and symptoms of hypoglycemia. Let me see if there's anything else we didn't. They can actually become unconscious, go into a seizure. They can have tachycardia, sweating, hunger, headache. I talked about blurred vision. And we talked about how you treat hypoglycemia. That 15-15 rule that we talked about yesterday. 15 grams of carbohydrates, wait 15 minutes. And then if they still have symptoms or if their blood glucose level is less than 70, treat them again. 15 grams of carbohydrates, wait 15 minutes. Okay, why is diet so important for this child?
Helps prevent spikes.
It has to be individualized for him because he's a child. Well, every diabetic, their diet's individualized. But it's really important because he's a child, because he's growing. We have to make sure that he has enough calories for growth and development, that he has enough calories if he, for instance, plays in sports. We have to take all of those things into consideration. You have to take into consideration his expenditure of energy i.e. is he playing sports, what kind of insulin dosage he has, and also you have to take into consideration the timing of his insulin doses. And the goal is we're trying to maintain a near normal blood glucose level. And I told you that one carbohydrate exchange is 15 grams of carbohydrates. 1 unit of insulin covers 15 grams of carbohydrates. Okay, we've talked a lot about exercise. Why is exercise so important for this child and for any diabetic, for that matter?
Better regulates their blood glucose.
Yeah. Exercise increases or decreases insulin resistance and increases insulin sensitivity. In other words, with exercise, that insulin can get into the cells more easily. Insulin also helps your cardiovascular system, makes your heart stronger. It improves your lipid levels. Did you know that if you're up walking around and exercising, that your lipid levels are going to be better? Your HDL, your good one, is going to be up, and your LDL, which is your bad one, is going to go down with exercise if you do that on a regular basis. And he should be exercising 4 to 5 times a week. Really should be exercising every day. And if he is exercising on a regular basis, and if he's playing sports, then that's something that the doctor needs to take into consideration, because he may need less insulin. And remember, we talked about with exercise, your diabetic, whether it's a type 1 or type 2, should check their blood glucose level before they exercise. They should have a carbohydrate. They should eat carbs before they exercise. They should check their blood glucose level during and after. They should have a snack with them, and they should eat carbs after they exercise, so that they will not have hypoglycemia during the exercising. And they should not be exercising when their insulin's peaking, because that's when their blood glucose level is lowest. If they're sick, they should not be exercising. If they have ketones in their urine, they should not be exercising. Okay. Why is the hemoglobin A1C so important? Why is it so important for us to check that? What do we mean by hemoglobin A1C? What is it exactly?
The life of the red blood cell.
Mm-hmm. It has to do with the life of the red blood cell. A red blood cell normally lives about 120 days, which is about 3 months. And what happens is that the glucose will attach itself to the hemoglobin molecule. And so they can look at that glycosylated hemoglobin, or hemoglobin A1C, and they can tell what the average blood glucose level has been over that period of time, the 3 months. And so the patient can't fake it. They can't come in and lie and say things have been great when their glycosylated hemoglobin is 8 or 9. Then the doctor's going to know that they have not been adhering to their treatment regimen, and that their blood glucose level has been up all the time. Okay. What nursing diagnosis would you develop for Jerry?
Knowledge deficit.
Oh, definitely knowledge deficit, because he's a new diabetic, right? Not only do we have to teach him, but we have to teach his parents, correct? And we're going to have to teach them to administer the insulin. How to draw it up, how to administer it, how to store the insulin. By the way, yesterday when we were talking about insulin, I thought later I didn't tell you a couple of things. One of the things about insulin is that you don't have to keep insulin in the refrigerator. We used to think you did, but it keeps longer if you keep it in the refrigerator. An unopened bottle will keep for about 3 months in the refrigerator. Once you've opened it, it'll keep for about a month in the refrigerator. So most people still do put their insulin in the refrigerator. If you don't store it in the refrigerator, you need to store it away from a heat source, so you wouldn't want to put it close to the stove. Store it out of direct sunlight, so you wouldn't want to sit it in the windows, on the windowsill. If it freezes, throw it away. You don't want to use it if it's frozen, because it probably messes up the chemical compound, the chemical makeup of the insulin. So if it freezes, you have to throw it away. The other thing is, because most people keep it in the refrigerator, when you take it out of the refrigerator, you need to warm it before you give it, and that decreases irritation to the skin when you inject it at the injection site. So you can rub it in between the palms of your hands like this to warm it. Don't shake it, because again, if you shake it, then when you draw it up, you're going to get bubbles. So, and so then you can't really read your syringe accurately. Okay, those are some things that I didn't tell you yesterday that I wanted to tell you. What about imbalanced nutrition? Do you think he could have imbalanced nutrition? Less than body requirements related to his inability to metabolize glucose? Yeah. And also risk for injury related to potential episodes of hypoglycemia and also ketoacidosis. So what are we going to teach Jerry and his family? Absolutely diet. Yes.
Self-monitoring of glucose.
Yes, we're going to have to teach him how to monitor his glucose. So we're going to have to have one of those little machines and teach him how to use that. What about the disease process? Do you think we need to teach him about the disease process?
Mm-hmm.
Yes. Of course, we're not going to use medical terminology. You have to remember, when you're teaching people, you have to think about their developmental age and also their educational, how much education they have, and adapt your teaching to the individual. Use layman terminology. One of the things you have to remember is that most people don't read at a college level. They read at a less than a college level. And so I think your newspapers are written at about a 3rd or 4th grade reading level. So you have to think about that. If you had someone who was an engineer and was highly educated, you might, your teaching approach might be different, but we're dealing with a child here. So, and you have to think about, their parents and how much education they have and how your teaching approach is going to be. So, disease process we talked about, medications, how to give his insulin, diet, you said. I'm sorry? Foot care is so important, because he's going to be a diabetic for the rest of his life, and he's only 13, so we need to teach him how to take care of his feet. And we talked about that yesterday. They need to wash their feet daily with warm, not hot water. Pat them dry. They need to inspect their feet daily. Look on the bottom of their feet, between their toes. Wear comfortable shoes that fit well. Wear clean socks every day. No garters. Don't go barefooted, even in the house. That's probably about the gist of it. But the bottom line is we're protecting the feet. And if they have an ulcer, if they develop an ulcer, they need to contact the physician immediately. And the reason we tell them to look at their feet is because many of them have problems with neuropathy and they don't feel an injury to their foot. And so it might be there and they don't know it. So, how to manage hypoglycemia, how about that? Do we need to teach them that? We also need to teach them, and especially the parents need to understand this, the importance of follow-up care. He needs to be seen every 3 months. And we also need to teach them the signs and symptoms of ketoacidosis. Yes?
Every 3 months because he's so young?
Yeah. Yes, and because he's a newly diagnosed. As he gets a little older, if he becomes stable, then the doctor might back off and it might be every 6 months. But even your type 2 diabetics, if you have a doctor that really knows what they're doing, they won't see their type 2 diabetics every 6 months. Okay, now this little guy was playing sports and he probably still wants to continue to play sports. So what are we going to tell the parents about that?
Make sure they pack snacks.
Mm-hmm.
discuss peak time and planning activities around when his insulin's at peak.
Right. They need to think, first of all, we said he needs to be under the care of an endocrinologist, so they need to talk to the endocrinologist about his involvement in sports. But just because he's an insulin-dependent diabetic, that does not mean that he can't engage in sports. His insulin dose might need to be changed because he's involved in sports. He might not need as much insulin. And anyway, exercise is important for children. We have too many children that are overweight because they're sitting in front of the TV or the computer and they're not getting out and playing. I can remember when I was growing up, especially in the summertime, our parents couldn't get us in the house. Even at night when the street lights were on and we were playing outside under the street lights, they'd have to make us come in. That doesn't go on anymore because children are involved in their electronics and the TV and their computers and all those kinds of things. So they need exercise.
My kids do. I show them outside and lock the door.
Well, that might sound bad, but actually you're doing them a favor to get them outside and make them play and move around. Okay. We know that exercise can help control the blood glucose, but it also can drop it if they've got too much insulin. So exercise is good for the cardiovascular system, and it helps the child maintain their weight. So we've already talked about when they need to check their blood glucose before, during, and after. They need to eat before, during, and after. Okay? And they should not be exercising when their blood glucose level, when their insulin is peaking. They need to keep a snack with them while they're exercising to prevent hypoglycemia. They need to have their glucometer with them so they can check their blood sugar. And it's real important if they wear an ID bracelet saying that they're a diabetic. If the blood glucose level, I think in the book it said several times, I think it said 230, it said it said greater than 300. One time it said 240, but if the blood glucose level, let's say between 230 or greater than 230, greater than 300, they need to check for ketones in their urine. And if their blood glucose level has been under control and all of a sudden they start having an elevated blood glucose level, they need to check for ketones. If their blood glucose level is getting high, they need to check for ketones. Did y'all learn a lot from this? Mm-hmm. Yeah, I think it's a good one. Let's get into the one with ketoacidosis, and when it gets close to 20 till, we'll take a break. We can finish this one because this one doesn't have as many questions. But I want to talk about this one because there's questions on the test about ketoacidosis, so I want to talk about this one. Remember yesterday we talked about diabetic ketoacidosis, and it's one of the complications that your type 1 diabetic can have, and it's when the blood glucose level gets high. However, the type 2 diabetic that has the hyperosmolar hyperglycemic situation, their blood glucose level can be really high, like greater than, I think the book says greater than 600, but if you look at other information, it says it can be up as high as 1,000 or more. So they are very, very hyperglycemic. Your type 1 diabetic that goes into diabetic ketoacidosis, they also are hyperglycemic, and so they're having all this glucose that's floating around in their bloodstream, and so their bloodstream is hypertonic, right? And so what's happening? Yes, ma'am. The body is pulling water from the cells and from the interstitial spaces into the intravascular space to try to correct that hypertonicity or that increased osmolarity. And so they're having osmotic diuresis, so they're peeing constantly. Peeing. Not only are they peeing, they're having polyuria and polydipsia. The cells are thirsty. They are thirsty. They're hungry. The cells are hungry because glucose is not being metabolized as energy. Does that make sense? Okay. So let's read about him. Anna is 35 years old and has been a type 1 diabetic since childhood. A school teacher, she is married and the mother of 3 school-aged children. Her schedule is full with her full-time position as a teacher, caring for her home and children and volunteering at church. She has not been sleeping well, and several days ago she developed influenza-like symptoms. Remember we said that diabetic ketoacidosis can be brought on by an infection? She goes to the emergency room to be checked out. She states she is very thirsty and hungry. She also reports that she is voiding more often than normal. There's your osmotic diuresis. She does not understand why she is so hungry since she has been eating constantly. Here's her physical examination. Her blood pressure is 120/80. Her temperature is 99. Her heart rate's 100. So that's still within normal range. Respiration is 28. That's a little high, isn't it? Fruity odor to her breath. What does that tell us? She's got ketones. There's ketones somewhere, right? Finger stick glucose too high to register on the glucometer, which is greater than 400. Her arterial blood gases are pH 7.25. Is she acid or is she base?
Acid.
Acid. The PCO2 is 24. What's the normal PCO2?
35 to 45.
35 to 45. And the HCO3 is, which is the bicarb, is 12. What's the normal?
22 to 26.
Or it depends on what you look at. 22 to 26 is okay. 24, the one I looked at said 24 to 26, but 22 to 26 is okay. Her chemistry profile, her glucose is 500. So they've drawn blood from her arm and her glucose is 500. Her sodium is 140. Is that normal?
Yes.
Yes. 135 to 145 is normal. Her chlorides are 111. Is that normal?
What is the range? 95 to 100?
I can't remember what the normal is. Is it 95 to 110 or something like that?
That's what I was
So
thinking.
this is barely.
95 to 110. Is
So,
that right?
so it's a little bit elevated. Her potassium is 2.5.
Very low.
Hypovolemic.
Yeah, she's hypovolemic. Does that go along with diabetic ketoacidosis?
Yes.
Yeah, it does. Remember I talked about that with diabetic ketoacidosis, because it's metabolic. Well, it is metabolic. That because she's in acidosis, the body will try to correct that. And because you have too many hydrogen ions, the hydrogen will move into the cells, the potassium will move out of the cells. But initially, her potassium might be low. So it depends on when you're looking at the potassium level. It could be low or high depending on when you're looking at it. Okay? So her potassium level is 2.5 right now. So she might have been in ketoacidosis. I don't know how long she's been in ketoacidosis. So let's explain the values that we've seen. We kind of did. We talked about the pH was acid. We talked about the PCO2 is alkaline. The normal is 35 to 45. The PCO3 is acid because it's so low, right? Mm-hmm. So she's in metabolic acidosis. The typical arterial blood gas values in diabetic ketoacidosis is a low pH. She has a low pH, doesn't she? And a low bicarb, which she has. What electrolyte imbalance are you so concerned about with her?
Potassium loss.
Potassium. Because the potassium is so important to cardiac function. With a too low potassium, with a too high potassium, what kind of problems is she going to get into?
Dysrhythmias.
Dysrhythmias, right? Dysrhythmias. Either way, she can die. Okay. The potassium is the electrolyte that is of most concern. She has hyperglycemia, which results in polyuria, and so she's having osmotic diuresis, and that can cause her to lose potassium. In ketoacidosis, the fats are broken down for energy, and so she has ketone bodies that are formed, and that increases the acid level of the blood. And so what does the body do to try to compensate because she's acid? Look at her respirations.
Too small.
Too small respirations. Also, potassium, as I already said, will move out of the cells into the blood, and hydrogen will move into the cells. trying to correct that. And we just said explain respiratory compensation with ketoacidosis. We just covered that, didn't we? The Kussmaul respiration. She's blowing off CO2. When y'all talked about acid base, did y'all talk about that chemical process that takes place in the body when you have carbonic acid and how it can break down and release hydrogen ions? Yeah, so that's what we're talking about. The more hydrogen ions you have in your bloodstream, the more acid you are. So, and so when you think about when that breaks down, it also breaks down, CO2 is broken down. So she's blowing off CO2 to help get rid of that acid. Okay, what medical interventions would you expect the doctor to implement with this patient? She's in diabetic ketoacidosis and she's polyuria.
6 to 10 liters of fluid.
Yes, we're going to give her lots of fluid. Probably normal saline, right? Are we going to give her dextrose?
No.
Why?
She's
Yeah,
already
it's got too
elevated.
much sugar in it. And she's already got a blood glucose level of greater than 500, doesn't she?
We give her insulin.
We're going to give her insulin. Why are we going to give her insulin? And we're going to give it to her IV. What insulin are we giving IV?
Regular.
Regular. Why are we going to give it IV?
Make it faster.
I'm sorry, what'd you say? It's a medical emergency. What?
Faster.
Yes. And because that insulin IV, regular insulin IV, helps move the glucose into the cells, right? It will also, if she's gotten to the point where so much potassium that has moved out of her cells that her potassium has gone up, it'll help move the potassium back into the cells also.
Is the regular insulin the only one that you can give IV?
Right. Now that handout, yeah, it's the only one you can give IV. That handout that's on Blackboard that she's got right there, it's got another insulin that I have never heard of. What's that last one there? Let me see that a minute. Please, ma'am. It's got a Velicillin. This is another one that can be used in the insulin pump, but not IV. It can be used in an insulin pump. But for the most part, it's the rapid-acting insulins they use in an insulin pump. I've never heard of that one before. So we're not going to worry about that one.
You could give her bicarb if her pH is less than 7. Is that the ring?
Okay, let me see what else I've got here on here.
You can give bicarb if the pH is less than 7.
Yeah. We need to monitor her for signs and symptoms of congestive heart failure because we're giving her all this fluid, and also for pulmonary edema. So we need to be monitoring her respiratory status very closely, her cardiovascular status very closely. We need to be monitoring her ABGs. We need to be monitoring her blood glucose level, all those things. She needs to be in probably ICU. Now, depending on where she is in this process, if the potassium is up, we're not going to give her potassium, but if the potassium is low, the doctor's going to order potassium. Right now, her potassium is low, so he may order potassium. And you just said sodium bicarb if her pH is less than 7. Okay, the last question is evaluate this patient's chemistry profile. What is abnormal and why? The glucose is abnormal because she can't get the glucose into the cells. She's hyperglycemic because she doesn't have enough insulin. The sodium and the chloride are both within normal limits. Her potassium is abnormal. The normal potassium is 3.5 to 5.0. Initially, in ketoacidosis, the potassium is usually decreased, but then as they move on into ketoacidosis, further into the disease process, the potassium will become elevated. Again, because the body's trying to correct the ketoacidosis and it's trying to move hydrogen into the cells, and because you have to have an equilibrium of those positively charged ions. If hydrogen, which is positively charged, moves into the cell, a positively charged ion is going to move out of the cell, and in this instance, it's going to be potassium.
if she also has something like wrong with her kidney, she'll have an increased potassium. I know this patient doesn't, but
Right.
because it won't push it.
Right. That what she's saying is if you have kidney problems, if you have poorly functioning kidneys, when you have a patient that has poorly functioning kidneys, they have trouble filtering out potassium, and so when you look at their labs, they're going to have a high potassium. That's why you need to make sure if you've got a newborn and for some reason the doctor wants to give them potassium, if their potassium level is low, they need to make sure that that baby's kidneys are functioning properly before they give them potassium. And also with an adult, you need to make sure that their kidneys are functioning normally before you give them potassium, because their potassium will go way up if you do that, if they're not functioning properly. Okay, let's take a 20-minute break, and we're going to come back. Do y'all, let me ask y'all's opinion. I'm willing to do that. Ms. Walker's willing to come in and start lecturing tomorrow morning